uterine hemorrhage is a fairly common reason that obstetricians, gynecologists may be called to the emergency department to manage. A patient with acute uterine hemorrhage can present with bleeding at any age in the reproductive life, and certainly the things that the emergency department physicians may have done before calling you are very important. You generally will want to know some information about the patient's hemodynamic stability. What are her vital signs? They will also have often ordered a hemoglobin or some type of blood panel so that you can assess if the patient is anemic or had any changes from recent screening blood work. These factors may allow you to go ahead and draw some additional laboratory studies, even if you won't be able to obtain the results in the emergency department. Patients with acute uterine hemorrhage who are potentially unstable will often be typed and crossed for blood products. And if possible, you would like to consider what types of blood work you might want to obtain so that you can draw these tubes and set them aside so that you may run these studies before the patient is transfused. Also, when you have a patient with acute uterine hemorrhage that might be potentially affecting her vital signs, you want to assess your interventions from more than one position in the disease pathway. You want to make sure that you've got the blood work drawn, you've got blood products in progress. You want to start one or more IVs so that you may give her fluids as well as blood products and medications. And you want to get an idea of some type of basic imaging. Often an ultrasound unit is available in the emergency department, or the patient might be able to be assessed by the technician who can bring a machine in order to just simply rule out some type of gross abnormality. The physical exam and the bimanual exam, however, will often give you some idea about whether the uterus and ovaries palpate to be within normal shape and size. Certainly, an experienced clinician will be able to assess the amount of bleeding, and the staff may have been measuring the weights of the drapes, the sheets, etc., and you may be able to get a ballpark idea of exactly how much blood loss the patient has had since she arrived in the emergency department. Then you want to consider the various medications that you can prescribe and the various physical interventions. If you have a patient with profound bleeding, you can certainly insert some type of device for a tamponade against the bleeding. So this could include a Foley catheter, either a 10 cc or 30 cc balloon, or it could include some type of uterine packing such as a gauze. This will allow you to begin to tamponade the bleeding in the uterus itself. Then you'll want to think about medications. So you may wish to begin some type of hormonal therapy, or you may begin some therapy such as tranexamic acid, which is an antifibrinolytic for the uterus, and this will begin to control the bleeding. Many hospitals have an emergency protocol so that this is available in the emergency department and fairly quickly able to be administered. Then you will quickly decide whether you need to have a sampling of the patient's endometrial lining, such as in somebody who might be perimenopausal or postmenopausal, or do you want to go ahead and begin some hormonal therapy? Certainly, if you're going to assess the endometrial lining soon, the almost simultaneous starting of hormonal therapy won't be a big issue. You want to provide hormonal therapy that will stabilize the endometrium and as well as help to stop the bleeding as quickly as possible.